Sudden cardiac death of athletes, though rare, is a shocking event for the family and often attract a lot of media attention. In the earlier era, once an athlete was detected to have heart disease, either due to symptoms, pre-participation screening, or family screening, they were excluded from return to play due to the perceived risk. But this simplistic approach is changing gradually as we have data from athletes who have continued to play even after detection of some forms of heart disease. An interesting article published in JACC discusses this aspect in depth and is worth reading for everyone likely to be involved in the decision-making process. Authors highlight the physical and psychological benefits of continuing to play and psychological trauma of prohibiting return to play. They do not underestimate the potential risks and analyzes the data from studies. They have cited data from a few studies evaluating the risks involved. Latest of these is on vigorous exercise in patients with hypertrophic cardiomyopathy, which was published in 2024. It was an investigator-initiated, multi-center prospective study. Self-reported levels of physical activity was classified as sedentary, moderate, or vigorous intensity exercise. This observational registry involved 42 high-volume HCM centers globally and subjects aged 8 to 60 years. There were persons who had HCM as well as those who had the genotype but was phenotype negative. Of the 1,660 participants, 15% were sedentary, while 43% participated in moderate exercise. Participation in vigorous intensity exercise was noted in 42% of the individuals, of which 259 had participated competitively. Study had excluded those with conditions precluding exercise. The primary pre-specified composite endpoint of the study included death, resuscitated sudden cardiac arrest, arrhythmic syncope, and appropriate shock from an implantable cardioverter defibrillator. A total of 77 individuals reached the composite endpoint of the study. 44 were in the non-vigorous group of exercise, while 33 were in the vigorous group. Hazard ratio comparing the groups was 1.01, which was not statistically significant. Another was a prospective international registry evaluating the safety of sports in athletes with implantable cardioverter defibrillator, published in 2013. The study had athletes with ICD aged 10 to 60 years, of which 328 were participating in organized sports, while 44 were participating in high-risk sports. Median age was 33 years, with 89 subjects younger than 20 years. 42% had history of ventricular arrhythmia before ICD implantation. The most common sports were running, basketball, and soccer. There were no death, resuscitated cardiac arrest, or arrhythmia-related or shock-related injury during sports over a median follow-up period of 31 months. 49 shocks occurred in 37 of the participants during competition or practice. 39 shocks in 29 participants occurred during other physical activity, while 33 shocks in 24 participants occurred at rest. ICD terminated all these episodes. 97% were free of lead malfunction at 5 years from implantation and 90% at 10 years. So, the trend nowadays is for a shared decision making, as in all other fields of medicine. It is a process involving the athlete, team physician, athlete's family, treating physician, disease specific consultant, athletic trainers, institutional stakeholders, and sports cardiologist. Decisions should be based on sudden cardiac death risk assessment and guidelines or statements provided by professional societies.